Yes, so corpus luteum cysts can be very different, but do they look like dermoid cysts and do they look like endometriotic cysts? Very rare. Corpus luteum cysts, so first you have to think upon them that they mimic everything. Okay, but they rarely mimic classic endometriotic cysts. The classic endometriotic cyst is full of that anogenic material. Or dermoid cysts that are bizarre, that have ordinary hyperechoic internal parts, bizarre parts. So rarely they are like this. They are, you cannot say. You see it's a cyst and it's not well, it does not look well.
Yes, they will check together.
What else? So you see follicle. How can we expect that you will see follicular cysts? What can be the characteristics of follicular cysts? Hyperechogenic or then see unechogenic. That means black the side.
With well-defined fine walls, thin walls, usually less than 6 centimeters.
That's brilliant. Dimension. Think about the dimension. You know, because if you have 12 centimeters,
suspicious.
Very suspicious follicular cyst. If you have 5 to 6 centimeters, very likely that it will be a follicular cyst. So, same image, but different dimensions. And you have to think the different ways. Okay, corpus luteum cysts can also be like follicular cysts. Can be filled with echogenic material. It will not be that homogen. So homogenic echogenic, but it will be non-homogenic echogenic.
Closer to the walls.
Yes, sometimes you will see also a thing that you can, the first thing that will occur onto your mind is a papillary structure. Very often is blood clot inside. So you have to think and come back of what I'm insisting on. Reproductive age. Is it after menstruation? Is it prior to menstruation? These things that maybe do not sound so very scientific, but can help you on the first time that you see a patient. Not to tell you the diagnosis. I think it's wrong to teach you that this one examination will tell you immediately the diagnosis. But the first visit has this idea that you have in your head what could be the diagnosis. And if you think that this could be something not good, then you will not wait for 3 months or 1 month, but you will send her to someone senior to decide, or to someone who will or will not operate, or to someone else, let's say. If you think that it's more probably that it will be something of these things that it's not so important, that means A, benign, B, functional, of course, better functional, and we see, let's check him out. So, functional cysts, follicular lutein cysts or corpus luteum cysts. We speak about endometriosis, we speak about dermoids. These are really what is common, and what is logic, and what is normal to expect in this circumstance. One thing that you meant very good is the first thing that you mentioned, and these are dermoid cysts. But what is not good to always think about the pathology. So about dermoid cysts, yes, because dermoid cysts can have no relevant symptoms and are often in this reproductive age. So if you have a patient of 30 years that have 2 babies that has no pain, just clinically thinking, if she'll have something that is not functional, it will be more probably dermoid than endometrioma. So you have also to think upon these things, not just the image. Because all this stuff will clear your mind in getting the diagnosis. If she didn't have any pregnancies, or so it's not or she has dysmenorrhea, she has dyspareunia, she has pains, you have to think about endometriotic cyst with no findings on it, with no even looking with the ultrasound. That could be. Take the ultrasound and see. Now, afterwards you get normal findings. You see 2 nice normal ovaries. Now what? You get on? Probably, yes, because ultrasound in the first phase of endometriosis cannot detect endometriosis. Endometriosis starts like small plugs on the ovaries and on the peritoneum, etc. And the first line of defense and diagnostics in the United States, it was not more than 10 years ago, it was diagnostic laparoscopy. I think that still, in the algorithm of diagnostics of endometriosis in the United States, it's laparoscopy, no ultrasound. Why? Because in the start of the endometriosis, laparoscopy can do much. They can do a lot with the coagulation of these plugs, and the conservative treatment is far more useful than when you have on ultrasound seen cysts. So they are more aggressive into this diagnosis. If you did not see anything, okay, then you may send her to diagnostic laparoscopy. This is one opportunity. Or second opportunity, you can think about all the possible causes, as small term infection, or inflammatory disease, chronic way. You have also always to ask her about the possible causes of dysmenorrhea, because if she had always dysmenorrhea, then it's probably primary dysmenorrhea and not connected with some of the causes that can be a cause of some disease or whatever. Endometriotic cysts. Do you know the signs of ultrasound endometriosis?
Carpet-like homogeneous hyperechoid with carpet-like echo.
Yes, but cystic structure. Not to forget, I know that you are thinking about the cystic structure and if you are speaking about the internal parts, but always say it, what you know, say everything. It sounds far more better. So cystic structure is dimensions. What about the dimensions?
They are usually 3 to 4 centimeters, but could be 20 centimeters.
Very all sizes. Endometriosis, all sizes. Ordinary, if it's very small, if it's 1 centimeter, then you will think, is it endometriosis or is it not? It could be a single part of the corpus luteum. It can be everything. So it's, in this situation, it's better to think about the symptoms. You know, if she had symptoms of endometriosis, that could be probably. If she did not have symptoms, then it's questionable. We'll get to another checkup in 1 or 2 months or whatever. If it's 3, 4 centimeters up to 6, 7, these are these findings that we deal with, in which patient has symptoms and come to the doctor. But really, that we have seen very large endometriosis. What is this? Just the structure. What is one very pathognomonical sign of endometriosis seen by ultrasound?
Changing the cycle, menstrual cycle, or necrosis.
Well, okay, yes, but I meant ultrasound. Ultrasound.
Ultrasound features or Doppler features? Without
Ultrasound.
Without
2D. No, doctor.
B-mode.
B-mode, just 2 dimension. Nothing more.
They are homogenic, hyper, echogenic, like
you said everything, but what else? What we did not say, you know it all. But you know what I'm thinking about. First thing, what?
It's on the surface of the leg.
That will be very difficult to say, you know, whether it is on the surface or it is inside. And it's mixed. But what about the second ovary?
It's normal. It could be 4.
So, it could be, right?
Additions.
Yes, it will be normal. It can be normal, okay? But
it can be bilateral.
Bilateral. If you have bilateral, because would be normal, of course. But if you have bilateral cysts that you think are endometriotic, we will not miss. You know, if you have unilateral cysts, always possibility that could be some corpus luteum that is missing. But you have on 2 ovaries these cysts that on the morphology you think it will be endometriotic. That it's very, very probably that it will be endometriotic cysts. And what else about the other ovary? What about the position of the ovaries?
They are close to the uterus.
In front.
To each other.
Yeah, so this is very nice phrase of kissing ovaries. They are first attached to the uterus, so first they are near the uterus, and afterwards with endometriosis they are going down the uterus, behind the uterus, and they are moving one to each other. So, you know the picture of the endometriosis, how it looks like. You know the diagnostics, or the clinical signs. You know that this is important because if you have, for instance, one side that you have, you suspect endometriotic cyst that is 4 centimeters, and you see the other ovary that is quite normal, and the ovaries are in the right position, this was suspicion whether you are correct or you are not. But If you have this ovary, that you have this cyst of 4 centimeters that is near the uterus, and the second ovary that is completely okay, that is attached to the uterus, even more if it's attached behind the uterus, you are very, very sure that it will really be endometriosis. So, cystic structures, bilaterality of the structures, that will tell you something, and finally, position of the ovaries. This will you remember, kissing ovaries. That means that they are one going to each other. Normally, you cannot even see when you're looking transvaginally. You are not able to see in one image the uterus and the ovary in the same time. You have to move it because the ovaries are away from the uterus. So if you see ovary near the uterus, this is the first sign. And the second sign, if the ovary is going, and you can image it as going, not good to say, but you can image it behind the uterus, or to the underarm. Now, what about dermoid cysts that are also often in this reproductive age? So, we have the same things. First, we are dealing with size and morphology. First thing. So, what about the size?
Different sizes.
10 to 12 centimeters.
Up to. Well, according to our operative findings, these cysts are around, that we operate are around 4 to 6 centimeters. About that. They are not so large.
Depends when we discover them.
Can be.
Yes.
Can be, but today, I don't know whether it's upon the ultrasound, upon the patients, but we discover them earlier than maybe earlier before. What about morphology?
Heterogeneous. Heterogeneous pattern.
Yes. Heterogeneous pattern, hyperechoic parts inside. Sometimes you may think of calcifications, because what is sometimes you have that
shadowing and fluid.
You have fluids, level of fluid, of echogenic fluid inside, of shadowing
and enhancement. We can have
hyperechoic. Sometimes if you're not careful, sometimes they can mimic the internal parts of the bowel and the content of the bowel. Yes, what about the size? We saw the morphology. We saw, what about the position?
Unilateral, usually.
Usually it's 95% unilateral. It's very rare are bilateral dermoid tumors. Very rare. That is an exception that they are bilateral. So ordinary unilateral. And what else?
And because they are usually heavier than other cysts, they could be placed anterouterine.
Yeah, so this is a clinical thing. This is a thing that, let's say, gynecologists before the ultrasound learned that if you have a palpable mobile tumor in front of the uterus, and you have a patient in reproductive age, it will be a dermoid tumor with no ultrasound because of the position, because we told that endometriosis is performing and is producing scarification, and is going the ovaries are fixed and they are going down the uterus, they're making adhesions with the uterus. Dermoid cyst, it's not making any adhesions, and it's very often anteverted, so in front of the uterus. So you, like a gynecologist on his exam, can evaluate it, where it is, this tumor. So also you, with the ultrasound, you can see whether it's down or up or in front of the uterus. So when you think about this stuff, not just the morphology is most attractive and the morphology is most important with the size, of course, but not forget also the position of the tumors that we are looking at. We are all speaking in reproductive age. We are all speaking in reproductive age. Why? Why just in reproductive age? What about if you see a tumor that really looks like endometrioma in postmenopausal age?
This could be immature.
Like endometrioma.
Yeah.
I'm listening.
Probably it's something, it's tumor, it's very mild.
Very good. This is a very good conclusion. It does not obligatory to be malignant, but the question is, endometriomas are produced in reproductive age. Now we are not speaking about the reproductive age, but postmenopause, so no reproductive age, and we have a tumor that sounds like endometrioma. It could be just two things. Or that is really endometrioma, it is, but the patient is not, or she did not have any symptoms, or she was not examined 2, 3, or 5, or 10 years ago. And this is really endometrioma. But you have to think first upon the it's endometriotic cystadenocarcinoma or cystadenoma. Okay, but this is something different. This is not endometriosis, but this is a benign tumor with endometry cells. So in postmenopause, what about if you see a picture that you think it's dermoid? Same thing. Always think in postmenopause, always can be that she was not examined good, or that she was not even went on the examination, and we can have this tumor as a residual tumor that is really benign from years. But it's not logic to think that way. In postmenopause, quite in the old and recent gynecologist books, it said every adnexal mass had to be treated as malignant until you are sure, or until it's evaluated that is benign. Every adnexal mass. Today there are different thoughts about this adnexal masses as small anechoic cysts of 3 to 4 centimeters that have no blood flow, no elevated levels of CA1 to 5, and that for all our knowledge seems to be benign, whether it's necessary then to operate classically. These are different thoughts. Some do not perform anything, some perform punctures, and then they send the material of aspiration on cytology. Cytology is not, we know that it's not so confident. It says its sensitivity, I think, of 50 to maybe 60%, not more. So it's not that it's ideal. But of course, it depends also on the patient. You have a patient with 80 years, you have a small cyst, and for her it would be very probably the operation. It's a hazard. So maybe it's better in this case to perform a puncture. Whatever. With the introducing of laparoscopy, we perform more and more laparoscopic annexectomies in these situations that we are, let's say, sure that it will be a benign procedure, and just remove the ovaries. It's not so. It's the operation. It's not so harmful, let's say, to the patient, and the patient is very. In a few days, she's on foot, and so this is a compromise. But then also it's a question of more conservative gynecologists say, why you perform the operation, you do not remove the uterus? Why perform the operation? So this is one field in gynecology where until now there is no algorithm, there's no approved word algorithm how to treat it. Okay. What about, you want to break or we'll continue? We'll continue until 12, for sure, because at 12 we have a pause for lunch, let's say. We have a meeting here, so if you want to short break now, 5, 10, 15 minutes,
No,
or
let's go.
should we continue until 12? What? That is great mimic and can mimic any tumor in the human body of ovaries, of course. And we are always in doubt whether it's something corpus luteum or it's not corpus luteum. The situation in postmenopause is far more obvious because it is the duty of the doctor to think that something is malignant if it's not normal. You know, in reproductive age, you may say, well, it's not normal, but maybe it's corpus luteum, maybe it's a small endometriosis, maybe it's small fibroid, maybe it's a small dermoid, maybe it's small. It's nothing that it will be of some great importance to the patient if you delay your diagnosis in 1 or 2 months. But in postmenopause and in the ovaries, it's quite different situation. So it's better for you that are maybe working already on the ultrasound machines, if you have a postmenopause and you have suspicious nasal mass, send her immediately to a senior or gynecologist or ultrasonographer. It's not that you have to send it, you know, it sometimes happens in our department that the death time at 6 o'clock in the afternoon, if it's you don't have a senior ultrasonographer. It's not a question of ultrasonography, it's a question of medicine. So send it to the senior gynecologist. Whether this person perform ultrasound or not. Because he'll perform a gynecologic examination and will see, wow, this is a really tumor. Or will see, I don't feel anything, I think maybe it's nothing. Then he will say to the patient, come tomorrow in the morning, let this senior ultrasonographer make an examination. Okay? Because it can happen that you say to the patient that has to perform color Doppler by this or that doctor tomorrow morning. And that the patient says, okay, goes to the nurse says, sorry, I cannot arrange it for you. Then she comes to another nurse, oh, the doctor is occupied, we'll see you in 2 weeks. So these are patients, some patients said, but they told me that I have to come tomorrow, I'm crazy or whatever, and okay, but try, maybe not this person, but that person or whatever. But the patient can also see, okay, in 2 weeks, in 2 weeks. So these things can happen, and you can be very precise in your diagnosis and what you are writing in the diagnosis. And that means examination, gynecological, right away. Move this to the image. So, one of the ideas of this Doppler polysonography that can detect angiogenesis. Now, a few words about angiogenesis.